Our next presenter is Esther Lei. She will be giving a talk titled Re-Evaluating Malaria Prevention Techniques in Zambia. And her faculty mentor is Danica Rocket.
Hi, my name is Esther Lei, and I'm a third-year student here at the University of Maryland, Baltimore County. I'm majoring in biology and health administration and public policy, and the topic for today, for my research, is re-evaluating malaria prevention techniques in Zambia. And I do realize that it's 2009 and not 2008. I'm sorry for the typo. I came across this topic when I was in Professor Rocket's class last semester, and we had to write technical reports. And I've been hearing about malaria in all my public health classes, so I did some preliminary research, and I found that Zambia is a country where it has a history of malaria diseases, but then also it's on its way to confronting the public health burden. And so I thought I could just do a case study on it and reevaluate the techniques that have already been used and implemented in this country. So the outline of today's presentation is I'm going to give some more background about Zambia and background about the actual disease malaria, why it's a public health burden, and then the solutions that I compared and contrasted were insecticide-treated bed nets as opposed to regular bed nets, DDT, which stands for dichlorodigiphenyl trichloroethane, which is an organic insecticide that's actually really toxic to the environment, but being reconsidered now for use again in underdeveloped countries, or still developing countries, and ACTs, which stand for, I don't know if I'm saying this right, but artemisinin combination therapies, which is a drug combination that's given to people who have already been identified with the disease. And then I'll give you the brief analysis of each solution and my conclusion. All right. So Zambia. Who's been to Zambia? No one's been to Zambia. Okay, it's okay. We have Google. You can go back and Google Zambia. But it is a southern African country, right above Zimbabwe, really close to South Africa. Its population is around 12 million people, and 45% of those individuals are less than 14 years old. It is one of the poorest countries in Africa, where malaria causes about 20% of child deaths. It has recently partnered with a bunch of different international organizations like UNICEF, World Bank, the World Health Organization, and hopes to reduce malaria incidence rate by 75% by 2011, which is only in 2 years. I'm not sure of their current progress, but they're working on it. And even though they're receiving help from all these international organizations, doctors are still reporting that there's not enough medicine, not enough bed nets, not enough resources to reach all the people who need it. So even though Zambia has increased its use of its bed nets, residual sprays, and anti-malarial drugs in the past 7 years, more than a third of all children under age 5 are still affected by the disease at any given time. Malaria is a parasitic disease. It's infectious yet preventable, which is why it's really sad that there are still a lot of people who are being affected by it. It's caused by there's 4 different parasites that can cause the disease, the most deadly being the Plasmodium falciparum parasite, which lives in the Anopheles mosquito vector in Africa. And this parasite is especially deadly because it attacks the brain, and if it's not treated immediately, it could cause death. And usually malaria is transmitted by female mosquitoes because the female mosquitoes are the ones that need the blood to develop their eggs. Malaria, so basically the life cycle of it is after infection by the vector, if it's a woman and she's pregnant, it automatically gets transmitted to the baby. If not, it goes into your liver and it infects your red blood cells. And if you go back to the previous slide, the parasite will just grow in the blood cell, and after a while the blood cell will lyse, meaning explode, and all the parasites will come out and reinfect your liver again. And it results in a cycle. The first symptoms come up 6 to 14 days after the initial infection, and it results in a cycle of symptoms, including high fevers, nausea, headaches, diarrhea, abdominal pain, rigors, loss of appetite, vomiting, and again, death if it's not treated immediately. Okay, and the reason it's such a public health burden in Zambia is because of the sheer number of people that are infected each year, of lack of doctors, lack of resources. And if you guys Google Zambia, you'll see that it's really pretty. It's a really lush, moist, humid landscape. That's where the Victoria Falls are. But it's good to see, but it's also really bad because that's where all the mosquitoes, breed. And again, it causes a third of all children under death of children, a third of all children under age 5, and the increased incidence causes negative impact on the economy as well, because it increases school absenteeism, decreases tourism, inhibits foreign investment, and even affects the type of crops that are grown. All right, so moving on to the first solution that I examined, bed nets. Bed nets can be hung over the center of a person's sleeping area, and it can cover up to 4 sleeping adults. The difference between regular bed nets and insecticide-treated bed nets are that the insecticide-treated ones, they not only prevent direct human contact with the mosquitoes, but it also kills the mosquito when the mosquito comes in touch with it. And it's really good for preventing mosquito bites early in the morning and late at night when the mosquitoes are most active. CDC, Centers for Disease Control and Prevention, says that about 20%, the insecticide-treated bed nets are about 20% more effective at reducing malaria-related mortality than regular untreated nets, and that transmissions can be dropped by as much as 90% if there was high coverage in a community, which is really beneficial for people who don't have bed nets. They can benefit from their neighbors. The second solution is indoor residual sprays. This spray can be sprayed on any indoor surface, whether it's the walls, the floors, the furniture, and because mosquitoes are endophilic insects, they have to land on the surface after they feed. So this is really, really good for killing them and preventing transmission between family members. DDT, as an indoor residual spray, has been decreased in production, mostly because of its toxic effects on the environment. But they're being reconsidered again because it has helped reduce malaria cases in South Africa by 80% in the 1990s. And the third is the anti-malarial drug, the ACT therapy treatment. There are 2 types of anti-malarial drugs. The first type is a prophylactic drug, which is taken continually to prevent the first initial infection of the disease. The second is a therapy type drug, which is what ACT is, and it's taken after the initial confirmation of the disease. It's taken in combination with other drugs, but the thing about it is that it's really expensive. So in places like Zambia, it's really hard to afford, and also because doctors in Zambia don't have the resources, like the diagnostic mechanisms, to really confirm confirm whether or not the patient has a disease. They've been overprescribing it, so there's been increased resistance among the mosquitoes to this drug. And criteria for each of them. The cost effectiveness of implementation refers to how much it costs for the solution to be produced, how much it costs to be distributed, if it's affordable to implement, and how accessible is it to all the people who need it. After analyzing all 3 criteria, I concluded that bed nets are the most cost effective. They have found that bed nets are usually given out for free during immunization campaigns and free local clinics in Zambia, and that increases the rate of vulnerable populations receiving it from 10 to 80% in 1 week. So that would be the most affordable for the actual Zambian citizens, but then this solution would have to be highly subsidized by international aid and foreign aid in the private sector, which Zambia is already receiving. The second criteria is operational lifespan of the solution, which refers to how often the solution needs to be replaced or replenished. And my conclusion for this was DDT was the most, had the best operational lifespan. There was a study done in Afghanistan saying that after 2 years of not spraying DDT on houses, mosquitoes are still dying because of the residual effects of it. DDT is most effective on hard surfaces, but in places like Zambia, where the houses are made out of thatched straws and roofs, it would have to be reapplied more often, and especially during the rainy seasons. The physical safety for users includes the environment, and I concluded that the ACT was the safest out of all 3 solutions. DDT, again, it bioaccumulates and it hurts animals, it hurts the organisms that are living around it. It's a carcinogen, it causes birth defects, it's absorbed into the water and soil and contaminates all that. Pyrethroid, which is the insecticide used for the bed nets, isn't as toxic. It's biodegradable, so it's safe for the environment. ACT is an organic substance that's created to cure the disease, so that's why I thought it was the most safe. And these are all qualitative analyses, by the way. And then the effectiveness of the solution, I thought it was important to look at that because I'm reevaluating the solutions that have already been implemented. And all 3 solutions are pretty effective, except they all have their own problems. The problems with insecticide-treated bed nets are, even though they work, it's really hard to get some consistent distribution of them in the different provinces throughout Zambia. The problem with ACT is that it's really expensive, and the problem with DDT is the environmental effects that it has. And so my conclusion, given all that data, there was more analysis and synthesis involved, but I concluded that the bed nets most effectively met all 4 criteria, and it can last up to 4 years if taken care of properly. That's why recommendations to go along with the distribution of bed nets is that you have to educate the users on how to take care of it and how to use it and where to live. Not to have standing water near their houses so they can avoid even the mosquitoes breeding near them. Pyrethroid, the insecticide used on the bed nets, again, is non-toxic. They do not harm the environment. And other recommendations to go along with the distribution of bed nets include combining that distribution with maternal and child health programs, like at the local clinics, constructing at least 1 community health center in each province to be a point of contact, and also to do follow-up education and consistent care for the community members. And then the 4th is to continue developing international partnerships with health organizations to help with funding and training of local volunteers. All right, and then limitations to my research. This is a meta-analysis of all the secondary research materials that are out there. I used journal articles that were printed in 2000 and from 2000 to 2009, so I didn't use anything older than that. And so this is just me kind of looking at all these different numbers and synthesizing my own interpretation of it. And my research hasn't been peer reviewed at all or anything like that. So yeah, and then so my acknowledgements, thank you to Professor Danica Rocket, who was my research mentor, and to Ms. McLean, who was the coordinator of URCAD. Are there any questions? Okay. All right, thank you.